Okay, thank you. Thank you very much for hanging in there. And thank you for fabulous cases. Um, Everybody, really interesting lecture and really, really nice cases, I have to say. And for the last lecture that I have, I wanted to focus on three areas that we didn't have time to talk about in my other lectures. And then I think it's relatively new, such that you may or may not have had a lot of exposure to it. So instead of kind of showing you typical cancers, I kind of want to focus on three particular areas, if you will, with the focus on the neoadjuvant systemic therapy follow-up, because I know that is increasingly used clinically, and that in this particular conference, I didn't have talk about that quite a bit. So anyway, so overview for the next 30 minutes or so. I'm going to focus on area number one, which is the targeted axillary dissection and preoperative localization of the clipped node. Number two, I'm going to talk about what I call exceptional response in neoadjuvant therapy and how that's a new and evolving paradigm shift in terms of how our clinicians, oncologists, treat our patients. And then three, Dr. Shippa, as well as Dr. Michael Lindver, talked about problem-solving MR. I'm just going to show one case of that kind of ties up to unify the themes, and that, that breast imaging, of course, it is about breast cancer, but many other aspects. And sometimes the subtle aspects are very nuanced and sophisticated and interesting as well. So on that note, and again, I am going to show like private patient data, if you will. I mean, not names or anything, but the natural course. So I do appreciate not recording it on cell phones, just because of my concern about patient confidentiality. So thank you. I appreciate that respect. Okay, so first topic. What is targeted axillary dissection? Okay, targeted axillary dissection is basically the excision of the sentinel nodes plus the excision of the clipped node, or what's called the marked node. And you will see in the literature that the clipped node and the marked node kind of mean the same thing. They are synonymous depending on who you read. But it is important that you notice that it is the sentinel nodes and this node. And at least one person, one radiologist, thank you very much, doctor, from the audience, asked me, like, well, what if you see three abnormal nodes, right? Which one do you clip? You just go for the one that you think is most suspicious and you can access in terms of procedure, biopsy, and clipping technique. And how do I know that's the most significant one? The data show it works, empirical. It is what is my best answer. But I understand the intellectual part of you want to know why, I can just say the data shows that. I'm going to show you some of the data, okay? So the clip node is the marked node, and that's a malignant node in axillary level 1, okay? Again, level 1. We don't clip level 2. We could clip level 2, but there's no need in a sense, because 1 and 2 are basically the same in terms of the surgeon's eyes. We don't do 3 or internal memory chain or any of those nodes, okay? Not typically anyway. So targeted axillary dissection, remember, is somewhere between a sentinel lymph node biopsy and a full surgical dissection. It gives you more information than a sentinel lymph node biopsy, but is less invasive than a full axillary lymph node dissection. Why do we care? Well, we care because of the complication of lymphedema, which could be pretty horrible. And I would bet that many of you in the room at least know someone who's a patient or a friend or a colleague or someone who worked with you who has lymphedema from breast cancer. Can I see a show of hands to see someone who knows? So I see, at least 10 hands or so in the audience. So it happens, and it's a significant morbidity. So like Dr. Shippa says, we want quality of life too, right? So not just mortality, but we also care about morbidity. So in a neoadjuvant setting, we want a downstage axillary disease as well as downstage breast disease. So we want to do less invasive nodal surgery, which is how targeted axillary dissection came to being. And this is our sort of most notable article still in the literature. There's multi-institutional trial ongoing, and there's been a few others. This was one of the first, and this was from MD Anderson in 2016, okay? Talking about experience, basically, with targeted axillary dissection. And it was found that, I don't know if you remember, but yesterday when I talked about the lymph nodes, I talked about the ACOSOG C10 trials. That talked about neoadjuvant therapy, and that's how different from the Z11 trial. Bottom line is that just doing sentinel lymph node biopsy is not enough, okay? Because the false negative rate is too high, 12.6. But if you do TAD, if you add that clip node, the false negative rate drops from 12.6 to 2, okay, in our hands at MD Anderson. So that's really good. So it's not 0, I know, but 2.2 is pretty good, right? You know, as a false negative rate, okay? We want 0, but we'll take 2, okay? And multi-institutional around the country in the United States, that rate is about, 5%-ish. Still pretty good, and definitely lower than 12.6. And I can share with you that I went to MD Anderson 8 years ago, and targeted axillary dissection was brand new to me, okay? Never really heard of it or been experienced with it, but now by far, the most questions I get from audiences and from interested radiologists or researchers is about our practice on targeted axillary dissection and what radiologists' role is in that. Okay? And I do believe that in the United States clinically, not just in the big centers, that this is becoming more and more popular. Kind of like neoadjuvant therapy, 20 years ago, 15 years ago, became more and more popular. So you see whether, these are correct words or not in the future to come. Okay, so again, avoid nodal dissection, reduce lymphedema in a group of neoadjuvant therapies. That's the goal. Well, the clipped node, is that the same as the sentinel node? The answer is no. And here's some data, okay? This is a meta-analysis, and you want to look at this column. Bottom line is that the concordance rate, you can see the numbers here, they are not 100. I mean, one study is 100, but many of the studies are not 100, okay? So meaning that it's not the same. Sometimes it's the same, but it's not always the same, okay? So radiologists have a job to clip the node and then to localize the node. And in our article in 2016, the clip node was not the same as the sentinel node in 23% of the cases. It is the same in, let's see if I can do the math, 77% was the same, but 23% was not the same, okay? So that's enough that you need to clip the node and localize the node for the surgeon. So therefore, need to localize the clip node for targeted axillary dissection to be performed. Various ways, tag 2, someone asked me about that earlier as well, wire. I will just talk a little bit about the non-wire, that's what we do. And I know that there's a cost issue, I know that, okay? But just to share with you what we do, let's put aside the cost issue for now. Not to say that you have to do it, okay? Just to share our ideas. There's radioactive seed, which is the least expensive, I-125, then these are much more expensive. The magnetic seed, the radar reflector, the radio frequency identification tag, RFID. I wouldn't be surprised if some of those are also showing up, maybe, in the conference here for their displays. So this is a review article from our group in 2019, non-wire preoperative localization systems. You can see the various devices here on the left, and what they have in common is the introducer, and then you have a handheld probe that's connected to a console. And when you get closer to these devices, they'll go beep, 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 beep. So you can find it, and the surgeon can find it. And you place it like you place a biopsy clip, whether it is a radioactive seed or radar reflector. I think the best way someone explained this to me is like submarine signals, okay? Don't ask me any more physics, okay? That's the extent. Magnetic seed is, magnetism, or RFID is radio frequency. All right, so pros and cons, like anything, there's good and bad, right? Chocolate cake tastes good, but lots of calories, right? So good and bad. So the good thing about these more expensive items is that you can be in the breast for a long, 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 long time. FDA says really months, there's no really upper limit, okay? Radioactive seed, of course, there is a limit, and usually the radioactive seed is 5 days only. Okay, upper limit, 6 days, 7 days, probably okay, but we aim for it to be 5 days or less. That's our goal, okay? Because it's radioactive, right? It's giving off radiation. Of course, so that means that you can do like your surgery and your placement of that seed in 2 different days. because, you can have even at least for 5 days for the I-125 and longer for these other devices. But of course, the challenge is the expense. Right? Look at the money here. Wire, we estimated $20 to $25. I-125C depends on how you get the I-125. Kind of like low of $5, upwards of $100. But look at these, hundreds of dollars for these other devices. Okay, for radar reflector, magnetic seed, RFID seed. So that's your problem, and of course, we recognize that and respect that. Okay, so our group, we do targeted axillary dissections a lot. I just want to show you that radiologists have a role, and an important role, really important role. Our surgeons cannot do this without us, and they readily admit that and acknowledge that. So let's look at a baseline neoadjuvant chemotherapy case. This is the lymph node. That's abnormal. It's involved. After 2 cycles, it looks better, but you see the echogenic focus. That is the clip. And then after 4 cycles, you only see that little dot. You don't see the lymph node anymore, which is good for the patient, bad for you when you have to be that on the procedure day, especially if you came back from, a long trip to Egypt, right, where you were jet lagged and had a lot of fun, okay? So that is really tricky. And of course, the actual technique is beyond the time we have, and it's much better done showing rather than talking. But a small point is that we measure the distance from here to the skin before, so we get an idea of what little dot we're looking for at the end, assuming patient responds really well. So we look for that dot. The skin, the distance from the skin helps us, to guide the localization for the TAD. And then we take that information. This is what our radioactive seed looks like. And this is the clip, and this is radioactive seed, specimen radiograph, just to share with you a little bit of what we do. Okay. Challenging to place the seed after neoadjuvant therapy when there is no residual sonographic target. Let's look at another case. Big axilla something, right? Something bad. Large lump, that's a lymph node, an abnormal adenopathy, palpable. That's our triangular mark that we use to denote palpable abnormalities. So there's a cancer here, probably this guy here, okay? But bottom line is that this is what I want to focus your attention on. And that looks like this. You know it when you see it. This is definitely abnormal. Some radiologists will say, well, why do you even need to biopsy? It's so obvious. That's kind of philosophical as well. Our surgeons, of course, always want the biopsy to confirm. What we say, tissue is the issue. Okay, that's one of the phrases we have. Regardless, here is our clip and our abnormal node. And we measure the distance to the skin because it looks really bad now, but it could be gone after neoadjuvant therapy. We hope it will be gone after neoadjuvant therapy. So just to show you the MR, that's what that looks like, that biopsy clip, that signal void, adenopathy in the axilla, in the sagittal plane, in the axial plane. And after neoadjuvant therapy, did it improve? Yeah, it improved. It's not gone, but it got better, right? Big, smaller, still there, still abnormal, but better, okay? So here it is photographically enlarged, and here it is photographically enlarged, okay? So it's not impossible because we do see a lymph node, but sometimes we don't, and it becomes really difficult. But we do see it in this case. So just to show you how we, in this case, used a magnetic seed, here is the needle deploying it into the node, and here it is right there, okay? We measure distance from that seed to the skin, and we also measure the anterior surface of the abnormal node to the skin. That's surgeons say that helps them, okay? So this is the mammograms afterwards, and then a biopsy clip, the magnetic seed. I'm pointing them out to you, and this is the specimen radiograph of the excised axillary contents, including the residual lymph node. You see that magnetic seed? That's what they look like. These are surgical clips. This looks a little different. You see the little bit of waviness here, and this ribbon-shaped is the biopsy clip. Okay, so that's what we do. So magnetic seed, unfortunately, causes artifact at MR imaging. It could look like that, okay? So if you think your patient's gonna go for an MR, we don't place the magnetic seed beforehand. This is called the extinction phenomenon. So we may choose a radar reflector if the patient's gonna, for whatever reason, have an MR before surgery, okay? So biopsy clip, that's the radar reflector. That's the node, and that's what that looks like on ultrasound. And here's the MR. You do have some artifact, but it's not as much as that magnetic seed artifact. All right. And the literature has reported that, the radar reflector, there's literature really on a lot of these things now, but the radar reflector has a little bit more published literature. It works, safe, etc. So that's what these articles are showing. But importantly, I want to talk about this, the yellow box here. Localized to node at the start of neoadjuvant therapy and not at the end, with or without additional marker clip, okay? And that was done in some of the articles, and this is kind of what I mean by that. No biopsy clip. Use the radar reflector or use the magnetic seed as the clip. So it's one procedure. Again, I know expensive, okay? Forgetting about that for now, okay? So for example, in this case, this patient had a radar reflector. You see these two? And you see that in the axilla? So what is done here in the breast, photographically enlarged, this is at a regular focal asymmetry, that is a big cancer, and that is the abnormal node, okay? But you see there's no biopsy clip here. That's the node, and that's the node with this, which is the radar reflector or the Savi Scout. That's the name of it, the tray name. But the bottom line here is that we don't have any clips. We just use this as a clip. The patient gets this from the beginning, so no need for a second visit at the end of the neoadjuvant therapy. Okay? Sorry? No. The question was, can it stay for 30 days only? We say at least 30 days was going to be considered, but months. It could stay for months. And FDA currently does not have an upper limit of the date. Okay, so we don't use it if the patient's never going to have surgery. We would like the patient to remove it at some time at this relatively early stage, but I'll be comfortable months, 6 months, 8 months, I would be comfortable. Okay, all right. So on that note, that was targeted axillary dissection, topic number 1. Topic number 2, we're moving on now, is this. I know there are many fashionable individuals in this room. Maybe I will pick on Dr. Hanan, who's very fashionable, I see in the front there, okay? And dedicate this to her, which is Coco Chanel. You guys know her, right? French designer, okay? And she's famous for her wearing all black clothing, very chic, with, pearls. And one of her famous quotes is, "Less is always more." Which means, you look in the mirror, last thing you put on, let's say my necklace, which may be too much for this outfit. I have to ask Dr. Hanan for advice later. You take it off because it's too much, okay? So less is always more is what I'm thinking. Well, that is fashion, but is it true also in neoadjuvant systemic therapy? And I lead to the magic word of the day, de-escalation, okay? In the United States, we have word of the year, right? I think 2021, the word of the year was vaccine, okay? And I forget what 2022 is, but I don't know, in our world, maybe de-escalation would be the new word, because that's a big word now, de-escalation. Less is more, okay? Because what we do can harm patients. That's the point. So very quickly, in terms of neoadjuvant therapy, 2 concepts. There is PCR and RCR. PCR, I think many of us have heard of. That stands for pathological complete response to neoadjuvant systemic therapy. Just good, just scarring, fibrotic reaction. No cancer left, good, really good. Good now, and it's a good prognostic sign for the future for the patient. 5 years, 10 years, hopefully 20 years down the road. Then there's a relatively new concept called RCR. We know that radiology is not the same as pathology, but as we get better and better and better, right? I heard about diffusion imaging in the pelvic lectures, as we get more advanced, can RCR be really, really close to PCR? And therefore, no surgery needed if there's nothing left in radiology. That would be a wonderful thing. At this time, not yet, okay, without technique. RCR is still not quite PCR. We still need to do surgery. And I'm going to ask in Egypt, when you have neoadjuvant therapy, even if there's nothing left at imaging, do you still go on to surgical excision? Yes? Okay. Anybody know? Okay, maybe if the patient's really old or, heart failure or otherwise sick, you may not. But typically you do, right? That's what we call standard of care. As Dr. Merritt alluded to in her medical legal lecture, standard of care. what is usually practiced. Well, we say, okay, standard of care, but can that be changed? Can we modify it after Coco Chanel and say less is more? Okay, so this is an article we have, which is really about, not about the results, but about what we're doing in terms of the trial. Okay, so how do you define argon at imaging? So we looked at the surgeons and the radiologists looked at, we call this the exceptional responder trial, meaning you really respond really, really well. Also known as the no surgery or the de-escalation trial. The idea is that a small group of patients who qualify for everything will not have surgery. They have observation, some of them may have radiation therapy, the different arms to the study, different cohorts, but no surgery. That's the point. Okay? And this is just to show that, mammogram, ultrasound, mammogram, FNA, core biopsy, FNA and core biopsy, vacuum, is the fact that these modalities is that the accuracy is the highest when you have some sort of biopsy, either FNA, vacuum-assisted biopsy, or both. The imaging alone wasn't good enough. So RCR maybe is imaging plus some sort of biopsy. And I'll show you what I mean by that, okay? And some of you may ask, and I'm sure our friend in the front is going to ask, what about MR? You don't have MR here. Great question. And it's just sharing with you at MD Anderson, we don't do a lot of MR. That's historical reasons. Maybe we can have a coffee and talk about why, okay? But other centers do, okay? But we just don't do MR, okay? That much. We do some MR, obviously. You see my images, but not as much as one would think. Just historical, okay? So vacuum, but the biopsy is what's really key. And what do you mean by that, Jessica? Well, what we do is that if you see nothing left at mammogram and ultrasound, and then we do the biopsy of the site of the nothing, and if still nothing at biopsy, then we say, okay, maybe you can be observed without surgery. Okay, so let me show you what I mean by that. Okay, exceptional responder trial. This, what subtype do you think this is? Take a guess. After Dr. Shilpa's excellent lecture today, luminal A, luminal B, HER2 positive, or triple negative? It's going to be one, it could be anything, but let's go with triple negative, okay? It's kind of like a mass, I don't have calcifications, and here it is at ultrasound, okay? My triple negative breast cancer. Is it a good response? Is it an exceptional response? We're like, yay, exceptional, right? Nothing left, okay? And nothing left at ultrasound either. Exceptional, wonderful, okay? But instead of saying, okay, oh, wonderful, great, randomized, eligible to be randomized into the observation arm, we say, no, we're going to do a biopsy because the data shows that we need to do that. So the biopsy, your target is this, which is the clip. Okay? Because you have nothing left on ultrasound, nothing left on mammo, you got to use the clip. And when you have clip only, rather than, of course, back then, we biopsied it under ultrasound, but now, because there's nothing left at ultrasound, the clip is better seen at mammography, right? So we're going to do vacuum-assisted stereotactic biopsy, or in Dr. Shilpa's preference, she's going to say tomosynthesis biopsy, but you get the idea. Same thing, okay? So here we are. We did do stereotactic biopsy. The protocol says must be 9 gauge or bigger. The protocol says at least 12 samples, okay? Why? Why couldn't it be 10? Why could it be, 11? Maybe, but that's just how our protocol is written in terms of the trial, okay? So this is the core specimens, and you see the biopsy clip? That was our target. So this was our target. We got it, okay? So we know we got that area. And if this shows no tumor, then she's eligible to be randomized into the no surgery part of the de-escalation trial, okay? And indeed, in her case, she didn't have any residual tumor. Sometimes they do, even if you see nothing, but she did not. And see, this was the first clip, and this is the new clip, because the first clip is now removed. Okay, so this is the new clip, and you can see through the shapes are different, right? You see how this shape is more like kind of like a safety pin, and this is more like a rod, right? So that's what we do, okay? So that goes to my case. Oh, and so that is, I said MD Anderson only, but this is an article from JAMA Surgery in 2020 to show, hey, it's not just MD Anderson, because this type of technique is being reported from around the world. We're talking about Houston, which is MD Anderson, London, the Royal Marsden Hospital, which is a big cancer center. Some of you may know it. And then Seoul, Korea, the National University in Seoul, Korea, which is a very prestigious institution in Korea. So this is a multi-institutional report. Okay, basically doing all very similar things. Some centers do MR, like I said, MD Anderson doesn't really, but all have in common the importance of the biopsy before the eligibility to be considered for no surgery. And who does the biopsy? You, right? We. And that's how we breast imagers play a really important role in all of this. So this study talks about a false negative rate of only less than 5%. Again, I want 0. But, I want to be married to Brad Pitt, and I'm not, okay? So we'll take the less than 5%, okay? So not bad, okay? So this is just to enter the trial, 2020. And then just very recently, December 1st, 2022, so 2 months ago, a month and a half ago, the results, our very, very, very first results were reported online at the Lancet Oncology. So really hot, what we could say hot off the press, it just happened, eliminating breast surgery for invasive breast cancer in exceptional responders to neoadjuvant systemic therapy, a multi-center, single-arm, phase 2 trial. So a lot of people, involved, exceptional responders clinical trials group, and this is from PubMed. I just want to acknowledge many of my radiologists, colleagues who are all part of the exceptional responders clinical trial group. Okay, great question. Dr. Mary asked the question. I'm going to repeat it. Do surgeons agree? Okay, so Dr. Kerr, by far, is the most support leader of any of this, all of this. He is a surgeon, okay? I don't know if his idea, whose idea very, very beginning, I mean, I'm old, but maybe not old enough to remember whose very first beginning, but I do know he's the one who talks about it the most, and he's definitely the lead author, and he is the lead investigator on all these trials. Okay, so, and he is a surgeon. So the answer is yes, surgeons agree. But that's a great question. And the answer is whether all surgeons agree probably depends on where you practice, et cetera. But I think that ultimately, with evidence and with what standard of care internationally is sort of, not really a matter of agreement, just a core biopsy. Probably surgeons didn't agree 15 years ago, but I'm guessing more and more do now, right? That core biopsy is the way to go, okay? All right, so the results of this December 1st, 2022 report was that what we're doing worked, and that is okay to not do surgery in some of these patients, okay? How many patients? At the end, we have 50, so not 1 million, but 50, and these are real patients you follow over years. These patients, subtype-wise, about half were triple negative, and about half were HER2 positive. Okay? And these patients respond well to therapy. That is either the neoadjuvant chemo or of course, Herceptin, anti-HER2, or Perjeta, anti-HER2 therapy. That I think Dr. Shippa talked about that these patients respond well to neoadjuvant systemic therapy. And that at the end, when they show exceptional response at imaging, and then we do the core biopsy, 31 out of 50, about 60%-ish, approximately, had nothing left at those core biopsies. Okay, so a little bit more than half. And these 31 were followed. They were followed for a median of 26.4 months, so a little bit more than 2 years. So not a long time, but something, more than 2 years. And there was no tumor recurrence in that breast on all 31. Okay, so to qualify, relatively small numbers, follow-up is 26 months, not 10 years, that's true, but whatever it's worth, first report, no recurrence, okay? Sorry? Okay, fair enough, 5 years at least, so question is, if you have $10,000 and you're going to invest in a technology or you invest in a trial, right, in the future, I understand your point, okay? So right now it's still a trial and not standard of care. And how long do you follow? 5 years? Is it 5? Of course, statisticians, do that kind of analysis. They also do analysis of many things like harms of surgery. They calculated that, and it's all about a benefits risk analysis, again, beyond the scope of this conversation. But fair point, that more long data, just like COVID vaccine data, right? There's a lot of controversy for that. The COVID vaccine, you don't have long-term data. But the COVID pandemic was thought to be sufficiently harmful that we're going to give the vaccine. It's all harms and risks, benefits, okay? So let me show you this case, and this is a private patient. This is why I don't want recording, because this is her story that I'm going to share with you. And so this is her cancer diagnosis year. Where is the cancer? Just, regular cancer, right or left? Right, okay, it is right. And I'm going to show you the CC, cranial card, it is right. This stands out to you when I show you your best friend as a radiologist, which is your prior mammogram. The year now and 2 years earlier, nothing, okay? So maybe a new mass, maybe a developing asymmetry. Okay, that's your finding on the CC, nothing there. Okay, so what are you going to do next? Ultrasound. So here it is, okay? This is the abnormality, and here is it on spot compression views. I call it a developing asymmetry. If you want to call it a new mass, that is okay. And then this is the ultrasound. Okay, of course, a mass. Of course, you're going to do ultrasound-guided core biopsy. You performed it, and the answer is an invasive ductal. In this case, it was a HER2-positive cancer. Good for these trials. She's given anti-HER2 therapy, Herceptin in most of these cases. These are the mammograms done after the clip placement. Now you have a bit of bleeding, a bit of scarring, right, from the biopsy itself. So these are mammograms after clip placement. 2 months later, okay, her ultrasound mass looks smaller. And like many of these sonographic lesions, when they respond, they look flatter, lower, less in the AP dimension. So I'm just showing them to you as this, the measurements, because they're subtle, so I want to point out to you. And just to show you what the clip looks like, right, at the edge of that little flattened. And 3 more months later, they really don't see very much now, okay? So come on, are you stuck? Okay, you're thinking. Okay, I'm going to tell you that 3 more months. Okay, here we go. 3 more months. We think we just see the clip. You see this echogenic focus? This echogenic focus? We think that's the clip, but we see nothing left. So we said, yay, great, exceptional response to this HER2-positive cancer. And look. Exceptional response, right? On the mammogram, great. Now what? Remember, what's our protocol? Biopsy, and we're going to do stereotactic, focusing on that clip. Okay, now this is 6 months after neoadjuvant therapy. We're going to do stereotactic biopsy now, okay? So we're going to say, is there disease? And this is the clip. It took us a lot of tries, okay, to get that clip out. It took us 24 cores in this case. Remember, 12 is minimum. It took us 24, but there it is. Never give up, okay? And these are your specimen radiograph images. The pathology shows no residual carcinoma, small areas of fibrosis with reactive changes to marker clip, consistent with treated tumor bed. So good. She can be part of the trial if she's randomized there, if she wants to be, of course. And so she did end up being randomized to no surgery cohort of the exceptional responder de-escalation trial, okay? So now we have a new clip. This is T-shaped at that site. And 8 months after the stereo biopsy, a randomization to the trial, she looks like this. Is there a developing asymmetry? Ugh. And 1 year later, she looks more. You guys see that? Okay. So is there a developing asymmetry? Now what? Biopsy or how? Stereotactic, again, maybe, but it looks like the developing thing is a lot more lateral, but maybe this is the clip is the edge of it, but okay, stereotactic. But what is the theme for problem solving that we've been talking about? Dr. Shippa, for sake of time. MRI is problem solving. So MRI was done as problem solving, followed by second look ultrasound. And this is the contrast MRI. I won't spend a lot of time, discussing it, but this is the area. We don't see very much, but look at this T1 non-fat set. Here's that scarring area, if you will. Do you see the clip right here at the edge? Remember, most of the abnormality is lateral to the clip, and here is most of the abnormality, right? Okay, and then here is the subtraction. I don't see anything, okay? And then here is the clip, this contrast enhance, and I don't see anything enhancing around the clip either, laterally or medially. So all that's suggesting this is negative, okay? So we did do ultrasound as well, and we see, some scarring, and, it's hard to say whether there's absolutely nothing. There's the biopsy clip, and, is there a scarring tracking? What do we do now? Is any action needed if negative predictive value of MRI is so high? Dr. Shilpa, I'm going to pick on you. I heard you say 100%, several times. Are you a betting woman? Do you say, forget it, go home, enjoy your life, or do you do something more? Follow surgery, it's hard, right? Because she's a special case, of these of the exceptional responder trial. Obviously, she didn't have her cancer excised. Obviously, it's a trial, only 2 years, not 5, only 31 patients, So all those things I said, we're going to do something more, and I picked on you just for fun, okay? And not to pick on you. Repeat biopsy, thank you. And that's exactly what we did. And we repeated the stereo biopsy, okay? Yes, we have a hematoma now, okay? We get it. We repeated it, and we went for a little bit more lateral. So we weren't aiming for the clip anymore. We were aiming lateral to the clip, and that's why we have 2 clips now in there. Everybody see? New clip here, more laterally. Okay, clip 1, clip 2, and there are 2 clips, okay? So specimen radiograph from this repeat, which is not part of the protocol, but it is done clinically because of what we perceived at mammography as a developing asymmetry. Core biopsy show parenchyma, stromal fibrosis, which is the cause of the developing asymmetry, along with therapy-related changes, negative for carcinoma. So it's been another 2.5 years after that repeat biopsy, which is 3.5 years from the very beginning of her entry into the trial, which is probably 4.5 years-ish since she was diagnosed. She's still okay, and she looks like this now, okay? This has been kind of smaller and getting smaller and smaller and kind of stable and no problems. So that's her story, okay? Do I have time, Dr. Merritt? Okay, so the last part is this, which is my last case, and this is not, wow, cancer, fungating through the breast, but just to consolidate our theme here of the MR and to show that, of course, breast imaging sometimes is about the subtle nuance, part, okay? So this is an review article I wrote back in 2010, maybe before some of you were breast radiologists. I know. That's how we're talking. Dr. Hananha and I have been many friends for many years. In 2010, we probably were friends, okay? So a long time ago, MRI in the evaluation of equivocal clinical imaging findings. Dr. Lindver, Dr. Shilpa others as well talked beautifully about that. 2018, okay, 8 years later, I wrote a similar article along with a junior colleague of mine at MD Anderson, Dr. Cohen, okay? So in this article, which is really the principles are the same, and the principle is the negative predictive value of breast MR, okay? But we have more data, is the point, by 2018. The data part is what's changed, and this is how the data part has changed. Yes, American and European guidelines now, no longer just SBI, we recognize USOBI, ECR, et cetera, the Europeans. But the point is the published literature, the data, is most supportive in 2018, pathologic nipple discharge. Dr. Shilpa talked about it many times, and others too, okay? And along also with that's the clinical symptom, but also with the mammographic finding of distortion, especially when biopsy options are limited, okay? That's red, so proven. Distortion and mammography, nipple discharge, that's pathologic, bloody, single orifice, et cetera, as a symptom. The blue, it's a little bit in the middle ground, calcifications, asymmetry, scarring, a little bit middle ground, but the green is don't do MRI as problem solving. That is your palpable lumps, breast pain, breast masses on imaging. Not to say they're not important, of course, a palpable lump is important, But the point is you don't need to go to MR, not as a first test anyway. And usually you never need to go to MR because mammography, ultrasound together with biopsy is so good. Okay, so red is yes, blue is, possibly, green is no, okay, because it's not warranted. So we don't do it just for fun. You do it because there's an indication, okay? So I personally feel asymmetry should be higher in the red. That's my personal feeling. And we've done some of the research on that, but this is kind of a review of all the literature, in the world. So I share with you this negative predictive value, and this is going to focus on developing asymmetry, which is a very favorite lesion of mine. It's almost my baby, because we worked on this when I was a fellow back in 2007, which became codified as developing asymmetry in the year 2013, which is when the 5th edition of BI-RADS was published, okay? So I'm very proud of it. We came up, Dr. Sickles and I, with the word developing asymmetry. This was our article that established that. So I say that too for sentimental reasons, because I believe that as in the 6th edition, which we expect next year, maybe this year, the end of the 2023, maybe 2024, developing asymmetry is going to be removed. I'm sad, and I fought for it because I'm part of the committee, because too many people feel developing asymmetry poses a medical legal risk. Like, developing asymmetry, did you not find it before? It's bigger now, I don't like it, And while we understand that's not what we mean, sometimes it's hard to convince our patients that, or our clinical colleagues that. Anyway, so thank you for allowing me the time to talk about it when it's still a BI-RADS term, okay? So let's look at this case of developing asymmetry. Baseline, nothing, okay? 2 years later, do you see anything? It's a very classic place. Right, focus on the MLOs, right or left? Okay, left, someone said, okay. 4 years later, definitely left. And then when I put them side by side for you, of course, it's much easier. And you can see in the left, upper or lower. Okay, so that's a nice developing asymmetry, right? Okay, these are chronological through the years. And then here's the tomosynthesis slice from the lateral to the medial breast. Lateral going marching, and then you don't see it anymore. So this, with tomosynthesis now, allows us to know that this is in the lateral breast, upper, outer, posterior breast, okay? What are you gonna do? Ultrasound, yeah, you're gonna do ultrasound. But of course, I'm going to tell you, you don't see anything, because that would be easy, right, if you saw something. Okay, so that's the finding on tomosynthesis. Oh, and we did additional workup. This is a 90-degree lateral spot compression, MLO spot compression. So there is something. It's not a mass. There's no abnormal calcifications. I don't really see distortion. But there is something there. And importantly, it's changed over the years, because I think those MLOs over the years was pretty convincing. Allow me to show you that again, okay? Because I think that's pretty convincing. So that's the temporal change over time. It's more contributory than tomosynthesis or any one test. It's a change over time. Okay, so that's your developing asymmetry. Persistence of developing asymmetry, but no mass or distortion. Ultrasound targeted, negative, okay? Because it was positive, then we can go from there. So MRI, again, is what was done. Okay, high negative predictive value, at least for invasive cancer. Look at this MIP, maximum intensity projection. Nothing, right? Okay, so, it's a good, technique, and technique, of course, Dr. Shippa talked about, really, really key. And we believe this is good technique, homogeneity, injection of contrast, etc. So we call this BI-RADS 1 negative. And when you look at the individual slices, what you have here, the color parametric map, you see this little something here? Okay, nothing on the subtraction, but there's no color, no enhancement. And here it is sagittally. I have this tissue, no particular enhancement. So it's not the absence of anything, it's the absence of enhancement. You can have tissue as long as the tissue is not enhancing. That's the point, it's the enhancement. So this is a T1 non-fat sat, non-contrast enhanced. You see this tissue here, and this is the normal lymph node, okay, with the fat and the cortex. And we believe that this developing asymmetry is fibroglandular tissue only, okay? The classic findings, if you biopsy this, is they could be PASH, pseudoangioma stromal hyperplasia. That's a differential. But the point is, I don't know what it is. It could be fibrocystic change. I don't know what it is, but I don't think it is cancer because it is not enhancing. So tissue, that's the developing asymmetry to node, as opposed to this is subtraction. You see how the node is enhancing, but not the tissue, okay? So that is our internal control that we have good quality MRI, okay? No enhancement, unsubtracted images, not cancer. So thank you for your time in that. I end with that, and I want to share my information. And I will get back to you. I think some of you have asked me about observerships and training or just questions in general about cases. Please feel free to contact me, and I'd love to hear from you. As we say in Texas, in Spanish, anybody speak Spanish here? My very poor Spanish, mi casa es su casa. My house is your house, so you're always welcome. Thank you.